65-year-old male who presents with a fever of 38.3, an absolute neutrophil count of 150, and a multinational association for supportive care in cancer, a MAS score of 20. He has a medical history of gastric cancer and is currently on trastuzumab, how do you say that? Deruxtecan. As you can see, I don't say it that often. The GFR is 80. What would be your initial empiric treatment for this patient? So the first one is cefepime, 2 grams IV every 8 hours. The second answer is ciprofloxacin, 400 milligrams IV every 12 hours. Piptazo, 2.25 grams every 6 hours, and Piptazo, 2.25 grams every 8 hours. Music. Well, it looks like they like Piptazo every 8 hours, so we'll see where, but they're pretty mixed across the board, so your talk will be timely for them. Tara's a 60-year-old female who started on trastuzumab. I'm not even going to try to say the last word. She presents to the emergency room with fatigue, shortness of breath, and dyspnea. She's diagnosed with grade 4 pneumonitis. What is the appropriate management for this patient? Is it to hold the trastuzumab until the patient is grade 0 and then restart it? Promptly initiate systemic steroids at initial dose of more than 1 milligram per kilogram per day for at least 14 days, followed by a gradual taper for at least 4 weeks, and then discontinue the trastuzumab, or permanently discontinue the trastuzumab. Deruxtecan.
Yeah, we're not known for making our drugs
easy to say,
accessible. CAR T-cell therapies are even worse. So.
Yeah. All right, well, it looks like they want to start steroids, so we'll see what you think about that. One more question. Which of the following medications should be considered for prophylaxis for high-risk patients that could potentially experience tumor lysis syndrome? Is it allopurinol, febuxostat, pegloticase, or rasburicase? Well, you're kind of split between the first two, so we'll see where it goes. All right. Thank you.
Yeah, thanks, Dr.
It's good meeting you.
Yeah. So thank you for having me and for being here. This is a really important talk because the therapies that we have now in oncology are markedly different than they were about 15 years ago. And the adverse event profiles are significantly different too. And so I don't expect you to be an oncologist when you walk out today. I expect you to be able to recognize, maybe not say, but recognize some of our therapies and have an idea and at least a framework for what kind of adverse events they might cause. I'll show you in just a bit that this is going to increasingly be a part of what you see in the hospital. Unfortunately, we cause problems that then we ask you to help us fix. And so I think if you put them all in a black bag and you say that's an oncology drug, yeah, exactly. So, I think if you put them in a black box and you say, this is just oncology drugs, they're on XYZ, and you don't think about the fact that you put them in a specific drug class, then I think it's going to make things harder. So with that, let's get started. I first want to talk about, so today I'm going to highlight 3 main drug classes that are increasingly being used. The first are the immune checkpoint inhibitors. The second are adaptive cell therapies, which I would put under that blanket CAR T-cell therapy and bispecific T-cell engagers. And the third group I want to talk about today is the antibody-drug conjugates. Each of them have a different profile. Each of them are going to be managed very differently and are going to show up in the ER or in the hospital very differently. So let's start with immune checkpoint inhibitors, which the other term that it's used is immunotherapy. Patients might tell you, I'm on immunotherapy, which is a non-specific term, but these are incredibly important and increasingly used, as I'll show you in a minute. Let's talk a little bit about the mechanism, because this is Nobel Prize-worthy work here that led to this discovery. So all these, the PD-1, PD-L1 inhibitors, the CTLA-4 inhibitors, and the LAG-3 inhibitors, which are less common, all, I think, in your mind, you should think about them as physiologic brakes for the body. That is, physiologic brakes for the immune system. They're telling it to slow down. Okay, so we have mechanisms in our body for the immune system such that if, for example, there's an inflammatory response going on, there's a kind of ongoing attempt by the body to say, okay, calm down a little bit, okay, because we don't want to over-rev the immune system. And so when I talk to my patients about immune checkpoint inhibitors, what I tell them is the immune system is a fire. It's an important surveillance system for cancer, not just for infections. And so what we're trying to do with these therapies here, the inhibitors of PD-L1, PD-1, CTLA-4, and LAG-3, are rev up that immune system, stoke that fire, if you will, hoping in the process of doing that we're going to induce the immune system to now recognize the cancer, which was hiding in plain sight, and kill it. Okay? So the toxicity profile is sort of going to be very much tied up in what we're trying to do with these therapies. I'm not going to go into the deep specifics of these mechanisms here, but the point is all of them is the same. These are physiologic brakes that our body has and that cancer exploits, because cancer wants to evade the immune system. All right, that's one of the ways that it develops. And so how does it do that? By upregulating the processes and the systems that our body has in place to slow down the immune system. Okay, so it sort of hijacks our own system. And what we're trying to do with these inhibitors is undo that. Okay, now we'll see in a minute, and the reason I'm here today is because sometimes we overdo that. Sometimes we turn that fire that we're trying to stoke into a bonfire that can be fatal and more often just dangerous. So we'll talk about that in a minute. I want to recognize the last thing I want you to get out of this slide is the names. So you're not going to, nor do you have to pronounce the names. You don't need to memorize these names. But anything with umamab, there's a decent chance that it's a checkpoint inhibitor. The most common ones that are going to show up in the hospital, at least for now, are pembrolizumab and nivolumab. And so if you see imumab, you should go, okay, wait a second. I think that's those checkpoint inhibitors. And you can check online, and it can give you that, confirm it for you. I'll also tell you that while we use these as single agents or in combination with chemotherapy, we also use them together. So, for example, the PD-1 inhibitors and the CTLA-4 inhibitors have been pushed together for combination therapy to try and maximize that effect of unlocking that immune system brake. And surprise, surprise, it causes more problems and higher toxicity rates. So that's the immune checkpoint inhibitors. And I'll come back to in just a minute to the kind of problems we can cause with them. The next class I'm going to talk to you about are the CAR T cells. So CAR T cells are also a very recent phenomena in the last 10 years in oncology. This is just showing the general structure of CAR T cells. CAR T stands for chimeric antigen receptor therapy. That is, we're taking cells from the patient themselves and we're slapping a new receptor on them. Okay? So just to give you a general idea of the process of what we're doing here, what we're doing is we take cells from patients. We take T cells from patients. Okay? So their own T cells. All right, remove their own T cells. They're sent off into a laboratory for processing. And what happens in that laboratory is a lentivirus, or several different viruses, but lentivirus more commonly, is injected into that cell to cause expression of a new transmembrane receptor. We're trying to mimic the structure of our T cell receptors, but we're doing it in a way that is more targeted. And so, for example, The most common one used today are the CD19-directed CAR T receptors. And that CD19 is expressed on B cells, particularly B-cell malignancies. And so what we'll do is you'll take the patient's cells, you'll send it off to a lab, you wait 3 or 4 weeks, and in the process, they inject that virus. That virus sends a receptor that the recognition point is CD19. And so in addition to that, though, as we've gotten increasing generations of CAR T cells, what they've added is, you can see that middle is starting to get a little bigger. And what they're doing is trying to increase the co-stimulatory molecules as well, because what we're trying to do is basically put seek and destroy missiles in the patient. Okay, so we're taking the patient's own cells, we're training them, if you will, at a off-site, and then we're injecting them back in and crossing our fingers that they will not only seek the cancer cells, kill them, but also continue to persist and replicate and clean up the rest. Okay, that's the concept. The names here are truly horrific in terms of ability to pronounce them. We don't even pronounce them. We break them all up and call them either by their trade names, or we say things like axicell, because trying to say axataptogene cellulosyl is not something anyone should ever have to do. So CAR T cells, I want you to think about as seek and destroy missiles we're putting in patients from their own bodies. Okay, because by doing that, we're also getting around the idea that if we just gave someone else's CAR T cells, the whole problem of essentially attacking a foreign invader. Okay, because there are pieces of it that are the patient's. Right, we're just slapping on a little change. All right, so that's CAR T cells. That also has a very unique mechanism in terms of the side effect profile. In the same group here are the BiTEs. The BiTEs are bispecific T cell engagers. This is pretty cool stuff. So this is off the shelf. This is not being taken from somebody and sent off to a lab. And I want you to think about BiTEs as matchmakers. Okay, so they've got 2 arms, and on one arm they take, for example, you'll see here a monoclonal antibody for CD3. So on one side, CD3 is a T cell marker, so they're going to say, hey, T cells of the body, come over here. So we'll bring the T cells in. Okay, and on the other arm, we choose a tumor-expressed tumor-expressed antigen. So, for example, in multiple myeloma, we have a tumor cell surface marker called BCMA, B-cell maturation antigen. And so what a BiTE directed against BCMA would do is take a T cell from the patient's body, attach it to this BCMA expressing cell, which is a myeloma cell, and then say, hey, let's meet. What do you think? And when you do that, what you're basically trying to do is prime the immune system to now recognize and kill in a cytotoxic fashion that cancer cell. Okay, so it's nothing more complicated than 2 arms trying to pull together the stuff we want to meet the bad stuff. Okay, so it's really that simple. And in terms of the side effect profiles, very similar to CAR T cell therapy. So I'll talk about that in a minute. In the process of doing all this, what we're doing is we're revving up the immune system in a different way, and so that can come with some unintended consequences. All right, but those are the BiTEs. Those are going to become increasingly more commonly used because they're off the shelf. That is, I don't have to wait after, I don't have to collect cells from a patient and then wait 4 weeks and hope their cancer doesn't overtake them. Okay, I can say, all right, next week we're going to start. Okay, but many of these patients will be started in the hospital. In fact, there are no drugs currently that are BiTEs that don't start in the hospital, at least for the first couple of cycles. And so these are things that are going to become increasingly common. At our center, we co-manage our patients with the hospital medicine team. And it's really important because while our cell therapies cause problems and they're trying to sort of understand what's the cell therapy, what's other stuff that can happen to people who have cancer, right? Fevers and infections. So those are the BiTEs. The last group here is the antibody drug conjugates. So people, when they hear ADCs, antibody drug conjugates, we think it's something very different. Really all this is a mechanism to give chemotherapy in a more targeted way. This is chemotherapy, all right? There's kind of no ifs, and, or buts. This is chemotherapy given in a different way. So what we're doing is we take an antibody, and on one end we have a target for the cancer cells, okay? So that target could be CD19, it could be BCMA, It could be a target on a melanoma cell or a breast cancer cell. Then we have a linker in between, and then on the other end we have the chemotherapy. And so what we're trying to do is send that molecule in, have it bind to the cancer cell, and then be endocytosed and offload its payload, okay, into the cancer cell, more specifically. Why do we do this? Well, it allows us to give higher concentrations of the chemotherapeutic agent than we would if we just gave it to the entire body. Because if we're going to do that, we're going to be exposing a lot more tissues to damage. But just because we have this sort of targeted approach where it's now being endocytosed doesn't mean that there aren't off-target effects. And the off-target effects are directly related to the chemotherapy agent being used. I'll show you that in a little bit, but there are all kinds of names and things like this. But and you can see in here, gemtuzumab ozogamycin and brentuximab vedotin. But I want you to focus in on that second name whenever you're seeing a patient like this, because the second name is the cancer drug being given, essentially. It's the payload. And so you can have 20 first names, but if the second name is the same, the vedotin, the adverse event profile is going to be very, very similar. Okay? So you don't have to memorize all these, and oncologists don't memorize all these either. We look at the second name. We say, oh, it's a vedotin. Okay, well, I know that the vedotin drugs can cause X, Y, Z. And again, as a hospitalist, you don't need to memorize all these, but I want you to recognize what they are. That sometimes people say, well, I'm on immunotherapy. Well, no, actually, you're on an antibody-drug conjugate, and that's chemotherapy. Okay, so some of the old chemotherapy side effects that we've dealt with in the past that you might be more familiar with are what we're going to be dealing with more with these. Okay. All right, so let's talk a little bit about the frequency and the issues that come up with these treatment. So let's start with the immune checkpoint inhibitors. I just was talking about how I explained to patients this fire, right? I got this little fire, I'm stirring, I'm adding a little bit of gasoline to it, and I'm creating a bonfire, and what can that do? Well, it can basically, I tell patients, it can create any itis in your body, all right? Any itis in your body. So thyroiditis, hepatitis, pneumonitis, colitis, you name it, myocarditis, cerebritis. So any of them. Now, I have this table on the left here to show you that some are more common than others. Okay, so if myocarditis occurred in 20% of people, these drugs would not be on the market. But I think it's important for you to have an understanding of the concept that if someone comes in an immune checkpoint inhibitor and something weird is happening to them, you know those patients that you go and you're admitting and you go, this is just weird. I don't know what's going on. You find that they're on an immune checkpoint inhibitor. You really need to entertain the idea that this could be some sort of autoimmune type process, because what we're really giving these people is an autoimmune condition. Okay, so these mimic the classic sort of autoimmune or autoinflammatory conditions that we see in other parts of the world, and particularly in the rheumatology world. So, what are the most common ones, though? All right, what are the ones that you're going to see the most commonly? Well, I would say the biggest ones that are most important from a hospital medicine perspective would be colitis. Okay, colitis, which occurs in with the PD-1 inhibitors, 2% of patients. I would say that that's probably an underestimate, actually, of what's truly happening. But in terms of hospital, the patients that need to be hospitalized for it, I'd say 1% to 2% is probably relatively accurate. Probably more than 10 or 15% are having maybe lower grade type of these reactions. Pneumonitis is also critically important because these patients are going to show up sick. They're going to show up short of breath. And the classic presentation is someone who is short of breath. So they're coming with dyspnea on exertion or shortness of breath at rest and have a dry cough. And you get that chest x-ray and you go, oh, is this like a viral pneumonia, which we've dealt with recently. And but then you get a CT scan and it shows some changes that are consistent more with the pneumonitis type picture. And you really need to start prompt therapy there, and we'll talk about in a minute what that is. Other ones that we see pretty commonly are hepatic, so hepatitis, and that's just your classic AST, ALT increase. Okay, typically those are going to be ALT, AST increases in the hundreds. We're not talking about the thousands. That's the shock liver and those kind of things that we think about. These are typically more 300, 400 AST, ALT. Okay, and so those patients, again, need prompt initiation of therapy and discussion. The last one I'll just mention here is hypophysitis, because that's one that sometimes can have more of a protein presentation. and that you might see in your hospital and not figure, what's going on here? So that's someone who might come in with issues with adrenal insufficiency. I've seen a patient who came in basically coming in looking volume depleted, and turns out in having orthostasis and things like that. Turns out they had kind of rip-roaring hypophysitis. So that's one you need a high index of suspicion for as well. So again, take-home point here. Any of the itises are possible. What are the most common ones you're going to see? Colitis, pneumonitis, hepatitis in the hospital, okay? Because those are the ones that happen most commonly. When do they happen? How often do they happen? It depends on the agents we're using. Particularly if we're using two together, there's a very high likelihood the patient is going to have an adverse related effect from their immunotherapy. And we take that chance because, for example, in melanoma, these combination therapies are potentially curative for people who have metastatic melanoma. And so we're rolling the dice. We're saying, I hope that I rev up your immune system just enough to kill all the cancer cells in your body without giving you a debilitating autoimmune condition, okay? And then also we found that there are certain tumor types that if you administer the same immunotherapy to multiple different tumor types, they have different profiles. That's probably just because of different presentation, antigen presentation within the body. For a lung cancer, for example, more likely to have pneumonitis. So, just interesting. Not as important from, I think, a hospital medicine perspective, but knowing that combination is worse than single therapy. And then the incidence. So I think this is an important slide because it shows you that hospitalizations are continuing to increase because we're using these more. You're going to see this. And on the right there, you can see that the percentage of hospitalizations caused by an IRAE, in between 2 and 4%. That's a lot of patients. That's a lot of patients being hospitalized for one class of drugs. Okay, one class of drugs. And so you're going to see this, and you need to have an index of suspicion for it because the initiation of therapy is critical. These patients can get really much better with steroids. And that's, if you learn anything from, internal medicine, I guess, as a whole, steroids are usually good. If some steroids aren't working, more steroids is probably better. But, I think this is a case where we've got a fire that's being revved up, and we need to calm it down. Okay, and steroids are going to be the initial approach for all these. And the different bars here are just basically showing you the different cancer types, and it's just based on the prevalence of how we're using these drugs in the clinics. What is a grade 1, a grade 2, a grade 3, a grade 4, grade 5 adverse event? I don't think that's quite as important for you because in the hospital side, if they're in the hospital for their adverse event, it's at least a grade 3. Hospitalization is a grade 3 event. Grade 4 is life-threatening. That means they're probably in the ICU. And grade 5 is they're dead. So 3 and 4 are what you're going to be dealing with the most in the hospital. And so that means that this is a really important adverse event. Nobody wants to be hospitalized. And so that's something that's big here. But I want to show you that you can see that the combination therapy is going to be patients that are, more than half of them, they're having combination therapy are going to have an IRAE that's at least grade 3. All right, so we're hospitalizing a lot of these patients who are getting these doublets. Okay. We also use it in combination with chemotherapy, and so then you're dealing with the fact that I'm causing some of the normal stuff with chemo. I'm causing the nausea and vomiting and diarrhea, et cetera. But now I'm also sprinkling in a little bit of immunotherapy. And so how do we distinguish between one versus the other? That can be really tough. And I think, for example, a great example of this is a patient who comes in on combination chemotherapy and immunotherapy with diarrhea. Is that colitis? Is that C. diff? Is that just diarrhea from the mucositis that's related to the chemo? Well, that's hard to distinguish. And so that's a case of, for example, you need to get a GI physician in there to do an endoscopy and biopsy and take a look. So it can be tricky differentiating them when people are on combination therapy. But important to recognize that this could be colitis because if you just send them home and say, here's some Imodium, we'll see, good luck. They may show back up in a couple of days with twice the stool output, okay? This is a slide to show you that if you haven't seen a lot of adaptive cell therapy and that I put under that umbrella CAR T cells and BiTEs, then you will, because we're going to use this more and more. And I think that what we're starting to do in oncology with these drugs is we're starting to increasingly use them as an outpatient And while that may seem, well, I'm going to see less of that, well, actually, that means that they're going to show up on the inpatient side in the ER. For one reason or another, as opposed to when we start them on the inpatient side, we're obviously watching them. We're watching them very closely, and the oncology team is probably involved. When we start moving these to the outpatient side more, you may have people showing up on these drugs going, I feel terrible, I have XYZ. Okay, but you can see that the use and the uptake in terms of trials is markedly increasing, and it's going to continue to increase because now we're using them not just in blood cancers, but now we're using them more and more in solid tumors as well. Okay, so let's talk about a little bit about the adverse event profile of these adaptive cell therapies. I've already talked to you about the immune checkpoint inhibitors, right? They can cause the itises, I don't know which one. Adaptive cell therapies, so CAR T cells and BiTEs, cause two main effects you should be aware of. The first one is cytokine release syndrome. Cytokine release syndrome. Basically what we're doing here is we're causing sepsis, but without an infection. Okay? So the side effects are the things you think about, and you've treated, all of you have probably treated sepsis and could do it in your sleep. It's the same stuff. It's the same stuff. It looks exactly the same. Fevers, hypotension, tachycardia, hypoxia, chills, etc. Okay? So this cytokine release syndrome can look all over the world like sepsis, but that's of course not what's happening here. We're inducing a really rapid immune response that can sort of overtake the body. The initial studies with this were very touch and go. These treatments actually almost didn't get off the ground because of some of the early adverse events that happened. And if in your ample free time, you should go and read the story about Emily Whitehead, who was one of the first patients treated with ALL. She was a pediatric patient with ALL treated with CAR T cell therapy at CHOP in Philadelphia. And she was incredibly ill. Shortly after her infusion, she was in the ICU on 3 pressors. One of the physicians sent just a wide profile looking for cytokines and found that IL-6 was markedly increased. He happened to have a daughter who was on tocilizumab for a rheumatologic condition, and he said, it blocks IL-6, let's try it. And within hours, she was off pressors and better. And so every year, she's one of the first patients cured, and so she's, I think, 15 now, and has a large foundation. But all that, I'd like to highlight, these patients they can get very sick very quickly, and so prompt recognition of that is important. Also important, though, that we don't leave our principles of medicine behind by saying, well, fluids can help. And thinking about the fact that these are cancer patients that are immunosuppressed as a whole, and so they can get infections too. And so I don't think you're wrong starting antimicrobials in these patients and treating them like sepsis in addition to initiating the discussions about could this be CRS, okay? Which there should be an oncologist helping you with this. But if there's not, you should go to them and say, could this be CRS? So timing of onset is important. So after, for example, a CAR T-cell infusion, the classic timing is about 2 or 3 days afterward. We'll start getting a fever, and then they'll get a fever, and then they'll get a little hypotension. The blood pressure will get a little soft, and then you'll get called they're on 2 liters, and now they're on 4 liters. And now we gave them a bolus, but their blood pressure is not going up. That's kind of your classic progression here of CRS. Okay, so we'll talk about how we can intervene and prevent that ICU stay. And it lasts about a week, although we're getting a lot better at how we intervene, and intervening sooner is better. Sooner is better, just like sepsis. The second toxicity that you need to know about with these adaptive cell therapies is immune effector cell associated neurotoxicity syndrome. We call it ICANS. Okay, and this looks all the world like your classic encephalopathy, which is a way of saying it can look like almost anything. The most common presentation for this is someone who starts acting funny, is the way I always say it. I had a young 20-year-old who was getting one of the BiTEs a couple of years ago, and we walked in. I mean, he was a totally normal 20-year-old guy, and we walked in one day, and he didn't know how to use a spoon. Okay, so it can be dramatic like that, but it can also be more subtle. They're a little bit sleepier. I'll show you some assessment tools we use to kind of get an idea if we're seeing some early signs of that. The most extreme form of this is seizures. Okay, seizures, but many times patients will progress to that point. So they will start to have some confusion, or they'll have some decreased levels of consciousness. You'll have a little harder time waking them up. They might look like a hypoactive delirium patient, okay, where you're like, hey, and then they'll kind of wake up, and then they seem to lose interest and fall asleep again. So they can kind of take many forms here. Typically, this is happening after cytokine release syndrome, okay, or kind of piggybacked on it. So it tends to happen a bit later in the course of the treatment here. But I would still, after that, if they've gotten the infusion recently, I would say still have to have high index of suspicion for these folks. One of the things I think is important is that you still kind of cast a broad net with both these conditions. So I told you to treat it like sepsis. With ICANS, I think you should look into other things, right? So what are the other things you think about when someone's delirious or altered? Well, maybe a head CT is in order, okay? Maybe we should get an EEG to look for seizures. Maybe we should evaluate for signs of an infection. Do they have a UTI? That can cause them to be altered as well. So I think we can't get too laser focused on the fact that, oh, this is ICANS, that's it. Other things can happen to these patients, and that's one thing I would harp, because we really, I think you all are the ones who are most adept at doing those things. Talk now about the ADCs, the antibody-drug conjugates. So I told you the key here is look at the payload. Look at that second name. And I've got here the payload and then the drugs using the payload and kind of their typical adverse events. I don't expect you, of course, to memorize this or keep track of all these payloads and what they cause, but you can see they're different. So some of them can still cause a lot of myelosuppression. Because they're still chemo, all right? And that's what I'll keep going back to on these ADCs is we're still giving chemo. We're just giving it in a more targeted way, hoping that we can minimize off-target effects. We're still causing off-target effects from chemotherapy, all right? This is chemotherapy. So, the things like neuropathy, which is a common chemotherapy side effect, are common with, for example, the vedotin drugs, which are becoming increasingly used in a number of settings. Here again is just several different payloads here and some of the drugs that they go with. And they range anywhere from things like ILD and cardiotoxicity to keratopathy, so really painful eyes. And I think for your purposes, it's important to just know, okay, this is an antibody-drug conjugate. This is chemo, okay? And you can always go look up what it is, things like that, and side effect profiles. But the second name is the most important one. The trastuzumab deruxtecan, one that's being used increasingly in our breast cancer patients, can cause things like ILD, right? So, coming in looking like a pneumonitis, and if you need to promptly recognize that and treat it. And just going back to that, we talked about pneumonitis with immune checkpoint inhibitors. These ADCs can do that as well. Trastuzumab deruxtecan particularly has a penchant for it, and occurs in about 5 to 10% of those patients. And so you will see these people because they will show up short of breath. And clinics, are oftentimes going to go, oh, you're feeling short of breath and you can't breathe. Okay, go to the ER, right? May not be warranted, but they oftentimes will show up, and they can be very sick, have that kind of classic pneumonitis type pattern, and be relatively protean at times as well in terms of what their CT findings are. I'm going to go back now a little bit to the basics here, because I've told you we're talking a little bit about chemotherapy of these ADCs, and I also want to be really, I think I want to also give you some clinical sort of pearls, et cetera, on things that are really high yield in terms of managing oncology patients. Those are neutropenic fevers, which I think are bread and butter hospital medicine oncology. And 2 is tumor lysis syndrome. This is just a slide showing you why people get tumor lysis syndrome and the manifestations. It's just the lysing of cells. And so when you break down the products, particularly of the DNA, you get down to xanthine and eventually to uric acid, which causes uric acid crystallization and kidney injury. Obviously, potassium and phosphorus are released with cell death, and so those will become high. A couple things that I think I've just noticed that are important that I want you to also recognize. So what are the patterns of tumor lysis syndrome? So hyperkalemia, hyperphosphatemia, hypocalcemia. Why is that hypocalcemia important? Because it's binding phosphors, phosphates, and so this calcium phosphate deposition in the kidneys is what's dangerous. Why is that important? Because you shouldn't treat hypocalcemia unless it is symptomatic. Because if you do, if you're giving them more calcium and they're producing a lot of phosphorus, well, you're going to make more calcium phosphate deposition. So the only time in tumor lysis syndrome that you should treat hypocalcemia is if they are symptomatic. That is, numbness, tetany, QT changes on their EKG, those kind of things. And that's pretty rare. That's pretty rare, even in people who are full-blown lysing, okay? So I think that's an important thing. You know, the hyperkalemia piece is hard because many times even people with good kidney function are going to have trouble if they're lysing enough. And so in the TLS world, we think of two things. There's laboratory TLS and clinical TLS. You can see the categories here for laboratory TLS. That's basically saying, hey, this is happening here, and they're at risk for clinical TLS, which is things that patients care about, right? Which is losing kidney function, arrhythmias, sudden death, those kind of things. So I think these are sort of like harbingers. They should be signals when you're starting to see those lab changes: hyperkalemia, hyperphosphatemia, hypocalcemia, hyperuricemia. You should go, this patient's at risk, and you really need to watch their kidney function very closely. I'll talk about the management of TLS in a minute. This is, there's a lot of text on this slide, but I think the most important thing is who is at risk for TLS? When do you need to worry about this? I think there's kind of two categories for me of TLS. One is spontaneous. That's someone who comes in, they're not on treatment, and they are lysing. That doesn't happen very often, but the people that it does happen in are Burkitt's lymphoma patients. It's a rapidly aggressive lymphoma that can literally double before your eyes. The doubling time of that cancer is about 36 hours. So you can see patients who come in with a golf ball and they end up with a softball in a couple days. And if that's the case, don't let the oncologist discharge them until they have the results of the pathology back. So if you see that, don't let them do that. But those patients are at high risk for lysing on their own. And the other group that is high risk are the ALL patients, acute lymphoblastic leukemia patients. They can lyse on their own. And the last group is people who have sort of the other classic acute leukemias or high-grade lymphomas like diffuse large B-cell lymphoma who have bad kidney function, right? Because they're not going to clear out the things that are produced by cell turnover. And so for these high-risk patients, if someone comes in, I'm obviously checking those TLS labs immediately. The other marker I really find useful is the LDH, okay? Because if they have an LDH over 1,000, I'm getting a little nervous, all right? I'm not sleeping quite as well that night, knowing that patient has pretty rapid cell turnover happening, okay? And that means they're going to be at higher risk for the clinical TLS things that we worry about. So in someone who has high-risk features, who has a really high white count with ALL or comes in with Burkitt lymphoma with a high LDH, or who has impaired kidney function, if that uric acid's over 8, they should get resburicase, okay? So resburicase is one of my favorite drugs because it's so satisfying. It converts that uric acid into allantoin. It's uricase, which is an enzyme that we don't make, right, as humans, but other mammals do. And so it's really satisfying because we're going to make that uric acid go from 11 one day till 1 the next day, okay? One little clinical caveat with that is that for the first couple of days, the uric acid assay will be thrown off by resburicase, so it can be spuriously low. It needs to be sent on ice for a couple of days, okay? So get that to the lab quickly if you want an accurate uric acid, but all that to say, it usually goes down, and it looks a lot better, okay? So I think all these patients should get put on allopurinol if they're about to start chemo and they have any of these malignancies I'm putting up here, which is not solid tumors, but any of the lymphoid or the hematologic malignancies. And allopurinol at 300 milligrams either once or twice daily. But resburicase you should employ prophylactically in patients who have that high uric acid and have some of these more high-risk malignancies, okay? Febrile neutropenia. So you all, I'm sure, have treated a lot of febrile neutropenia, defined as an ANC less than 500 with a fever. I think they say, consecutive temperatures. I tell patients, if you've got 100.4 or greater and you might be neutropenic, you need to go, okay? Get checked out. So, the kind of initial approach that everyone has, obviously looking for a potential source. I think one thing that I think about with these folks is there's this mass score we're going to talk about in a minute, just kind of risk stratifying. Maybe you don't need to calculate it every single time, but you need to have an idea of what patients are at higher risk for complications, what patients are at lower risk. Some of that is just good old-fashioned common sense, common clinical sense that you have. But there are some other features that maybe you're not as aware of that we'll talk about in a minute that go into the mass score. And some of these patients can safely be treated as an outpatient, Now, once they're in the hospital, that's obviously not going to happen. They're in the hospital. It's not your decision at that point. But just knowing what patients are at higher and lower risk. And then the last thing I'm going to talk about in a little bit is when to employ vancomycin, when do you need it, when you don't, and what kind of should you start out in terms of the initial workup. The NCCN guidelines, which are our cancer guidelines, group neutropenic fever patients in the high risk and low risk. And really that's based on how long do we think they're going to be neutropenic, how severely are they neutropenic, how bad is their cancer, and how sick are they, okay? So the only patients that can really stay outpatient are people who are just transiently neutropenic, who have great performance status, look great, don't have a malignancy like AML or ALL that is at a higher risk of complications, and have good kidney, renal function, kidney function and liver function. The rest of the patients need to be admitted, and that's the majority of them. That's the majority of these patients, because the last thing I'll say is, we're talking a lot about communication between hospital team and other members of the care team. So it's not your job to know how long someone is expected to be neutropenic from their cancer therapy, right? It's not your job to know, I expect that duration of neutropenia to be at least 7 days. Well, that's a discussion, right? That's calling talking to the oncologist either on call or the patient's community oncologist saying, hey, how much longer do you think they're going to be neutropenic? Because that's an important piece of the puzzle here. So let's talk about some management tools. The NCCN joined up with another organization to put together a tool for immune-related adverse events in their management. I think it's a useful tool. It's easily accessible on the computer. You can Google the NCCN management tool for IRAE. It'll take you to a website where you just have to quickly register. They don't, you don't have to they don't take anything from you. There's no fee or anything like that. And then it goes through the organ affected. It goes kind of through what their organ affected is, what are their symptoms, and it'll give you at the end a recommendation about what you should do. Now, some of this is for the oncologists to know, right? It's not going to be your decision whether or not they should continue their immunotherapy or not. As a general rule, we're not going to be giving immunotherapy in the hospital. All right? So if someone's admitted, most of the time they should not get their immunotherapy while they're in the hospital. Okay? Why is that? Well, twofold. One, they're fish to fry, okay, so to speak. But the second part of that, and also the hospital isn't super excited about paying for these very expensive drugs. But two, some of these patients, the action of the immunotherapy is ongoing. So whereas the traditional chemotherapy drugs we give in cycles, we'll give every 3 weeks, and the effect of the chemotherapy lasts about 2 to 3 weeks, and then it wears off. And if you don't give them any more therapy, they're not getting more therapy. Immune checkpoint inhibitor therapy, actually, the effect persists because we are revving up that immune system, and that is a continuous process. Okay? So someone who's gotten their last immunotherapy 2 months ago can still absolutely get an immune-related adverse event. Someone who discontinued their immunotherapy 3 months ago can still get an immune-related adverse event. Okay? The most common time to get those immune adverse events from the checkpoint inhibitors is in the first 2 to 3 months of therapy. But I've seen patients who, a year in, will have those. I've seen patients who have been off the therapy for a month or two. So don't just assume that because somebody's not getting it actively, they can't get a checkpoint inhibitor toxicity. Does that make sense? So that's an important piece of the puzzle here is our therapies are still working, okay, presumably for some time, even if they're not getting them. That's different than traditional chemotherapy. And that's different than, for example, the ADCs, which are kind of like traditional chemotherapy, like we've been saying. That effect is, once the cycle is done, it's over. The ADC they got a year ago is irrelevant to their current presentation. The checkpoint inhibitor they got 3 to 6 months ago could be relevant. You should at least consider it. Okay? Pivoting a little bit to our adaptive cell therapies and the management of cytokine release syndrome. So I do think it's useful, in my mind, to start thinking about how we grade these, because that does really influence how I treat these patients. So I told you that it looks like sepsis, and so the severity in our approach, we've gotten increasingly aggressive with when we decide to employ our therapies. And really, if you think about what our toolkit is for treating these CAR-T-related or the adaptive cell therapy-related cytokine release events, we've got a couple things at our disposal. One is things like fluids, right? Supportive care. The second thing we have at our disposal is tocilizumab, which is the anti-IL-6 therapy that people are, you're probably a lot more aware of because of its use at times during COVID. The third thing we have is steroids. The thing I'll caution you with steroids is we are injecting T cells into patients. So we're giving them bites or we're giving them CAR T cells. And steroids are toxic to lymphocytes. And so there has always been an underlying concern in the oncology community that is at times been more or less supported by evidence that if you give someone steroids immediately after they get a CAR T cell infusion, you might actually kill the seek and destroy cells you were just trying to use. Okay? So I would say that while I am going to talk about immune checkpoint inhibitors and the fact that we should be using steroids pretty judiciously with those, for these I think you should have a pretty thoughtful discussion with the team about whether or not we should employ steroids. So let's talk about the algorithms that we typically approach here. I've put in the red box here grade 3 and 4 because these are the ones that are going to most kind of that need most kind of aggressive care. But what is grade 1 CRS? It's a fever. It's a fever. Okay, fevers, chills. So if someone just has an asymptomatic fever, which most patients who get with the current second generation CARs will get, they will very likely get a fever. Okay, and we just treat those with supportive care, Tylenol. Okay. Now, when we get into things like hypotension and a little bit of oxygen requiring a nasal cannula, that's a grade 2 event. Grade 2 CRS is a bit more controversial in terms of whether or not someone's going to intervene with tocilizumab or not. So typically our approach, and the approach of a lot of centers, is to give fluids. So you give a fluid bolus if they're hypotensive. If they respond immediately, then you can continue to wait. But if they don't respond immediately, they should get tocilizumab. Okay? And then anybody who's moving into the grade 3 territory, which is someone who's moving towards pressors, right? They're no longer fluid responsive hypotension, or their oxygen requirement is increasing over that of a nasal cannula. So they're getting face masks, they're getting a non-rebreather, those things. You should definitely be giving that person tocilizumab. Okay? Grade 4, that's people who are very sick. They're in the unit, they're on pressors. They should absolutely have gotten tocilizumab, and they should be getting it every 6 to 8 hours. Okay. When to employ steroids? So, on here, and this is the NCCN type guidelines here in terms of management, they talk about using steroids for grade 3, and I think that's reasonable. We're getting a lot more aggressive in terms of using tocilizumab early on, so we're seeing a lot less grade 3, which is on pressors. These grade 3 people, they're in the unit. Okay, these are ICU patients. So if they're in the unit, I think it's worthwhile, it's reasonable to use steroids, okay, because we're trying to save their life. And in addition, they're getting tocilizumab. The use of other drugs like anakinra and other types of medicines like that are used in our refractory patients. Those are anti-IL-1 therapies, and those are used maybe in the grade 4 setting. ICANS, so this is this grading system that we use for ICANS. The first easiest one is just level of consciousness. Okay, if they are not responding to tactile stimuli, then that is a high grade. That's already grade 3. Okay, ICANS. If they have seizures, then they're immediately going to be grade 3 or grade 4. And any focal deficit, that's a grade 3 patient. I would say, in terms of your evaluation practically, you get called on this patient, okay? You're either covering them or you're taking care of this patient. They call you and say, hey, they're kind of acting funny. I think those patients, you have a low suspicion to go see them and order a CT scan of their head and talk to neurology about an EEG. And those kind of things, I think, are you're never wrong doing those things because, again, these patients have a higher risk of seizures as well, and so some of these can be even subclinical. So I think that it's good to be aggressive with these patients in terms of that initial workup. We don't need to be too resting on our laurels. The treatment in terms of these, in terms of ICANS, is really steroids for the most part. It's been much more effective than tocilizumab. So I told you that sometimes they go hand in hand with CRS, so you may be giving these patients tocilizumab, but steroids is sort of the bread and butter treatment. Anybody who's moving into a grade 3 adverse event needs to be given steroids. Okay? And grade 2, I think, is a discussion between you and the oncology team, and maybe even the neurology colleagues if they're involved. ILD, pneumonitis, and I'm going to also kind of I'm going to kind of use this as a jumping off point for all checkpoint inhibitors. So really the treatment for most checkpoint inhibitor toxicity that shows up in the hospital is steroids. Okay? Typically the answer is going to be 1 mg per kg of steroids. And the only group that I make sure we are giving IV methylprednisolone in is in patients who have colitis because of worries about absorption. So our pneumonitis patients, if they can swallow, sure, they can take pills. But I think you're never wrong giving someone a big slug of steroids up front in patients who show up with a grade 3 adverse event from their immune checkpoint inhibitor. This is the recommendation, for example, we just took this from trastuzumab deruxtecan. So, these patients who show up with grade 1, so you won't see grade 1 because that's just on the CT scan. Those are asymptomatic patients. So that's the oncologist who's getting a surveillance scan and going, there's some pneumonitis they're calling. Okay. But things like grade 2, grade 3, that's when you promptly need to really intervene with the steroids, a 1 mg per kg of a prednisone equivalent, and then that's a very gradual taper, because if you taper them quickly, it comes right back. So it has to be a gradual taper. People who have events that are causing them to be hypoxic, symptomatic with their ILD, with the pneumonitis type picture, those people probably shouldn't get that drug anymore. Okay, and that's the case for the immune checkpoint inhibitors as well. Okay, so there's a little crossover here between this ADC, in particular, trastuzumab deruxtecan, and some of the checkpoint inhibitors. But if you see someone on pembrolizumab who comes in with shortness of breath, they have a pneumonitis type picture, if they're in the hospital, they should be on steroids. Okay, and you should work. This is a great example of maybe you've recognized that, you treat them, but you're going to want to discharge this patient in the coming days. You need to be thinking about communicating with your community oncologist about the adverse event. So for 2 reasons. 1, they need to know not to use that drug anymore. Okay. 2, they need to start thinking about this next drug they want to use if that patient's cancer is still active. And that can sometimes take time. I really, really, really appreciate it when a community oncologist gives me a call about a patient that's not in our, went to a hospital, not in our system, and they say, hey, I got this patient, I know that he was on, this drug. He's been treated here for the adverse event, and I go, okay, that's great. When are they going to be discharged? When do I need to set up the follow-up? And then immediately after that conversation, the next thing I do is go, okay, well, can I continue this now? And if I can't, what do I need to do? And so I'll start actually the prior authorization process for the next drug, and by the time I see them next, maybe the time, within a week, they're getting out of the hospital, they come see me, I have that next drug approved, I have an infusion slot for them. So there's practical pieces here that make differences to patients. And if you communicate with the outpatient oncologist, it makes a world of a difference because it allows us to prepare that as opposed to them showing up and going, oh yeah, doc, I was just in the hospital. Oh, okay, why? Oh yeah, well, I was short of breath. Okay, what did they give you? Well, antibiotics and maybe some steroids, I think. And are you still on the steroids? We've all had those conversations, and you're going, okay, well, I need to pivot here. We need to stop this, cancel that infusion, get this one. And that's challenging. And also, these patients, many of them, you've met these patients with cancer, they can be very ill. They can be just on that edge, right? And so, being kind of having that kind of foresight and ability to do that. I talked just 2 days ago with a doctor who was taking care of one of my patients with myeloma. He was telling me, okay, I think she'll be ready to get out of this rehab facility in about a week and a half. Okay, oh, great. Then the day after she gets out, I've got her infusion ready. I'm going to see her that day, and we can get her therapy going so that she doesn't end up back in the hospital with the same complications she started with because she's 3 weeks now. Okay, so really important. I just wanted to highlight that. TLS patients, this is all patients. Give them allopurinol. Fluids. Dr. Palmer wouldn't be disappointed to see lots of fluids. Got to protect those kidneys as much as possible. These patients need to be on telemetry, watching their eyes and nose. How often should you watch their TLS labs? If they're high-risk patients, I think every 6 hours is reasonable up front. That first 72 hours is when people are going to get TLS that's clinical. And if they're high risk, then think about resburicase. Only treat symptomatic hypocalcemia. Okay? Neutropenic fever, so this is the MASC index over here. This is just looking into the things that are what is making someone a higher risk or lower risk patient. Again, you may not be making this decision, depending on your institution. You might not be making this decision. The MASC score, the cutoff is typically 21 in terms of if they're over that. If they're under that, then they're considered to be high risk. And if they're over that, then they're considered to be low risk. So you can see here, all these things on here are the things that are good, right? So they're outpatient, they're young, they don't have a high burden of disease, they don't have COPD. So the higher your MASC score, the lower risk you are. It's nice and confusing. I really appreciate the MASC people for doing it like that. And then patients who have a low MASC score, that means that they have hypotension and COPD and they have a hematologic malignancy, those kind of patients, those patients are much more likely to need inpatient therapy. And in terms of what we use, so patients who are in the hospital, I think IV cefepime is the recommendation from the NCCN. Because it's what we're trying to cover is Pseudomonas, and while Zosyn certainly does that, we're not as worried about anaerobic coverage, and obviously the renal function in these patients can be tenuous. So cefepime is their initial starting point. I get a lot of questions about when to start IV vancomycin and what the data supporting that is. If they're really sick, start vancomycin, use your clinical judgment, right? If they're going to the unit or they're looking very ill, you're never wrong starting broad spectrum antibiotics. I will never tell you not to do that. But when can we omit it? I think patients, when they come in, cefepime and neutropenic fever, cefepime is standard. You start it, you don't have to think about that. But what am I looking for starting vancomycin? I think we should be looking for evidence of, look at their lines. Many of these patients have ports or PICC lines. Do they have signs of infection there? Do they have bad mucositis? Okay. Are they coming in with big mouth sores and ulcers? Well, that's a person who's at higher risk for having mucosal breakdown, a potentially gram-positive bacteria going through. And then obviously you need evidence of like cellulitis, things like that. But if they don't have a clear catheter-directed indwelling infection, if they don't have bad mucositis, and they look relatively stable and look pretty good, I think you can actually forego vancomycin in a lot of these patients. And then the algorithm from there, I think if they're not getting better despite that initial kind of upfront therapy, if they're not on vancomycin, potentially add that. And then if you don't have any they're still having fevers and you don't have any clear source, obviously involving the infectious disease team to help, but that's when you're starting to think about, the mold infections and those kind of things, okay? So let's go through some cases together now. This is Tom. He's a 67-year-old male. He has non-small cell lung cancer. He got his last treatment 2 weeks ago. He coming in with 4 days of water diarrhea, now having 9 to 10 loose stools per day and not eating very much. And despite not eating much, his diarrhea is persisting. He's got an elevated white count. He's got an acute renal insufficiency, acute kidney injury. Potassium's a bit low, and he has a hyperchloremic metabolic acidosis. So what is the next best step for this patient? So most of you are checking C. diff and getting GI involved. I think this is kind of what I went back to before. We can't forget about, while obviously checkpoint inhibitor colitis is at the top of our differential here, could be C. diff, right? Could be other things that we can easily reverse and treat. So I think it's really important up front in that first evaluation to cast that broad net. I wrote these questions intentionally because I don't think all these are all that wrong. I think there's just a better answer. I think checking a C. diff because of its common, these patients that have cancer have commonly colonized with C. diff because they're in the hospital infusions or in the hospital a lot. And so I think you're certainly not wrong doing that. And then why could GI help us? Well, certainly if the C. diff is negative, they go and scope the patient. They can tell us that it looks like they've got checkpoint inhibitor colitis, or hey, something else might be going on. So I think that's the answer number 4 is the best. So C. diff is negative, but GI came by and they said, I've got golf this afternoon. The weekend's coming up. They look pretty stable. Just give them some fluids. We want to make sure we get a really good prep. We really like that good prep. So maybe like 4 days of go lightly would be good. And we'll scope them on Monday or Tuesday maybe, or somewhere in there. So, what would you do next? What would you do next? Like steroids. So if some stories are good, more is better. I think that's what I would do too. Again, I wrote these questions because I don't think all of them are that wrong. I don't think any of this is certainly malpractice. But this is a patient with a high suspicion for checkpoint inhibitor colitis. Okay, they're on an ICI. They've been on it for 6 months, kind of in that most common window period. And I think the other answer E would have been having a discussion with your GI colleagues about the quick speed of their endoscopies. But again, intervening early with steroids is important for these patients. I've seen a couple patients that were discharged from the ER with diarrhea, with loperamide, who had checkpoint colitis. Okay, and then they come back in sicker, volume depleted, et cetera. So it's just understanding that this can happen to people. Okay, that's the number one thing. Once you've thought about it, then I think it's really you've done 90% of the work here. So this is just kind of going back to that management tool. What would it tell you to do? You're talking about the GI side effect. It would tell you how severe it is, and then give you the recommendation to start steroids here. Okay. And again, this is where a situation where I would definitely use IV methylprednisolone, not prednisone or oral drug because of the absorption concerns. Let's do case 2 here. This is Sarah. She's a 48-year-old, history of metastatic HER2-positive breast cancer, 1 week of progressive shortness of breath on exertion, dry cough. She's getting trastuzumab deruxtecan under the care of her oncologist. She got it 2 weeks ago. She's got some crackles on exam. She's on 4 liters of oxygen. She's got a left shift. She has a normal NT-BNP. And this is her CT scan. It's beautiful. All right. So what would you do next? So love the steroids. I agree I would be most concerned about steroids for this patient. When would I think about posaconazole or think about an invasive fungal infection? That's what we're getting at with number 3. I think about that in our patients who are neutropenic for a prolonged period of time. Less than ANC, less than 500 for about 4 to 6 weeks is when we start to really see those invasive mold infections get much more common. Also in our patients who've got things like acute leukemia, acute myeloid leukemia, who are repeatedly immunosuppressed. Trastuzumab deruxtecan can certainly lower your blood counts and give transient neutropenia, but I wouldn't expect it to be long enough to increase your risk of an invasive mold. So I think, steroids, bread and butter here, getting that started as quickly as possible, and very much, you're likely to get them off oxygen quickly if you do that. All right. So this is John. He's got relapsed diffuse large B-cell lymphoma. He was admitted by the oncology team. You're co-managing for an infusion for, I'm just going to call it Axicell because that's what we all call it, Axicell, which is a CAR T product. On day 4, he starts getting a fever, and his pressures get a little bit soft. His baselines were in the hundreds over 60s and 70s, and so you're called perhaps overnight about what to do about this patient, and what would you do? So obviously we love steroids. It's actually a case where I wouldn't give the steroids right away. So if you were on the steroid train, that's okay. And you've been right twice in a row, so I get going that third time wasn't a bad choice. But I think in this case, supportive care. So stick to our internist principles here. Fluids, treat them like sepsis, because that's what it looks like. And I can't tell you it's not sepsis. Okay, so treat it like sepsis, and give that fluid bolus. I think answer choice C was a very reasonable choice, actually. This is teetering on grade 2, although I would still probably call it grade 1 CRS. And so there are oncologists out there who would have that quick trigger and give that tocilizumab. But I think the best answer was given that fluid bolus, broad spectrums, give a couple liters of lactated ringers, and blood pressure not any better. Now we're starting to get a lactic acidosis. So now what do you want to do? All right, so some of you are starting those pressers, which I think is probably right. All right, so there's more than one answer here. I think that's correct. I think I would be definitely giving at least I would be giving tocilizumab. I would be starting them obviously on supportive care. I'm not going to let them die without pressors while we're waiting for that to work. But tocilizumab, the response is going to be quite dramatic. And so if you're seeing that blood pressure go down and you're now talking to the unit about, hey, blood pressure's getting a little soft, I'm giving some fluid boluses, you should be already initiating that tocilizumab at that point with, obviously with the discussion with the oncology team here. And steroids, as now we're getting in here to grade 2 and now, moving towards grade 3 CRS. And so, I think this is a point where we'd start thinking about it. I would give the tocilizumab before I would give steroids. So I want to see if they're going to respond, because many patients will rapidly respond to the tocilizumab. But if they don't, then I think that's when I would start pulling for my steroids. Okay? All right. Well, let's kind of summarize the discussion so far. I framed our initial talk, my initial talk today about, the cancer adverse effects you're going to see today in the next 20 years are much different than that we've dealt with in the last 20 years. And so I think understanding these classes of drugs, understanding what they're doing and why what they're doing is going to make the adverse effect profile different is important. You don't need to know the drugs. You don't need to know when to use them, et cetera. Like that's oncology. But what you should be able to do is recognize this is the class. These are the possible kind of general things that can happen with that class. Should I be thinking about this? Should I be thinking about colitis here? If someone comes in and they're on trastuzumab deruxtecan and they come in with colitis, it's not from the trastuzumab deruxtecan, all right? But if they come in on pembrolizumab, it certainly could be. So recognizing that there's differences between these new drugs. I really want to, I really want to emphasize that they can present in any organ system. All the itides are possible with these immune checkpoint inhibitors. And so if weird things are happening to a patient on one of these, you need to really have an index of suspicion, say like, could this be the drug? Could this be checkpoint inhibitor colitis or something like that? Checkpoint inhibitor hypophysitis? Checkpoint inhibitor cerebritis? I think the question needs to be asked. ADCs, antibody-drug conjugates, are just chemotherapy given in a special way. And the toxicity is dependent on that payload, the drug that's linked to them. So you can just drown out that first name, okay? Look at the second one, and that is going to be what causes that toxicity. The cellular therapies, which are CAR T cells or BiTEs, we're going to be using these more. I am using these more. I'm now starting to use these more as an outpatient. I'm giving patients infusions, and we're trying to find ways to minimize inpatient time for these folks. One thing that's important with these cellular therapies that I didn't mention is they're much more common up front, and they're related to tumor burden. So if someone comes in with a ton of leukemia and you give them one of these drugs, they're very likely to have CRS. Okay, but if you debulk them, they have very little leukemia left, the chances of them having that are much lower. And with subsequent infusions, if you give, for example, one of these bispecific T-cell engagers, if you're giving that for cycle 4 or cycle 5, the likelihood that that's now going to cause CRS is low. So just thinking about what's my sliders in terms of my level of concern. I think this top one is really important. So ask your cancer patients what they're getting. If you say, hey, I have breast cancer and I'm coming in with an infection, I'm neutropenic, and you ask them what they're on, and they just say, oh, I'm on some treatment or chemo. I think trying to get them to give you their names at least, so that you can figure out, are these one of the newer things? Is this pembrolizumab? Is this ipilimumab? Is this nivolumab? Okay, because they might be getting chemo and immunotherapy. Okay, and that could change the things that you might be thinking about. These are just kind of a approach to just general problems. Don't ignore that AST, ALT when they come in if they're on a checkpoint inhibitor. Make sure you're looking for pneumonitis and shortness of breath patients. And then in terms of TLS monitoring, this is kind of bread and butter stuff, but fluids. Watch them closely. Get nephrologist help if it's not getting in control. Not everybody needs vancomycin. I think it's fine to be aggressive in patients that you're worried about, but there's a group of patients that don't need it. And then I think this last one is, the last thing I really want to emphasize. I want to finish it with, because, I think that I told you that story earlier about the oncology, the hospital team calling me about a patient who was in the hospital and letting me know when they're going to discharge. Not just so that I can, there's multiple reasons for this. One is I can maybe help you. I can maybe tell you, oh, yeah, I just gave him pembrolizumab 3 weeks ago. this could be pneumonitis, you know, or you know, they got an ADC 8 weeks ago. Like, this is not related. You know, this is something else. And that can be important as you're evaluating a patient and going, do I need to think about the cancer therapy causing this adverse event? So there's context here, and you know, oncologists' jobs, we're trained to manage these side effects, but if we don't know about them, our patient is in a hospital system, and piggybacking on one of the questions that was earlier, you know, we've got all these different hospital systems here that don't talk, right? So, you know, if I have a patient who I take care of at Baylor and then they end up going to Medical City, well, I may not know it. I may not know it, and maybe I can help and lend help to that. But at the very least, if I can't help, if it's, you know, something that's just, you know, they came with neutropenic fever and they're getting better or whatever, we can at least also coordinate that safe landing on the outpatient side. And it also allows me to plan my therapies for them going forward, as opposed to scrambling the day they show up in clinic, trying to furiously request the records, figure out what happened, and decide what I want to do with their therapy. So I think really important. And then when you do talk to that oncologist, what are they going to want to know? The malignancy they have, the therapy they're on, and when they got the last treatment. That's what they're going to want to know, and that's what you should ask the patients. And that's what the consulting oncologist would want to know too if you get them involved. So, all right, that's
great.
That's all I got. So we do the post-test.
I will grab that.
Yep.
Thank you. Great talk. Please give Dr. Christensen a round of applause. Let's see. This first question, Sam, 65-year-old with fever of 38, ANC of 150, mask of 20, has a history of gastric cancer and is currently on trastuzumab, GFR is at 80. What's your initial empiric treatment of choice? Music, tell me what you guys think. All right, well, most people are going with cefepime.
Yeah, they're crushing it here. You know, the mass score is the kind of key part here, and it was really nice of us to make that 20 is when the cutoff's 21. But you know, for me, I think it's just thinking about the risks for those patients. If they have a mass score that's low, that's worse. They're higher risk. So I think everybody identified that. And you know, if there's on the outpatient side of things, it'd be Cipro, but it'd be oral. So you know, we're talking about best IV therapy for this patient, and I think cefepime is the best choice among others.
Great. Tara is a 60-year-old female who has started on trastuzumab, presents to the ED with shortness of breath and dyspnea, grade 4 pneumonitis. What's your management? Excuse me, sorry. Well, what do you think?
Yeah, no, I mean, I think this is definitely a steroid situation. You know, you're gonna stop the trastuzumab, but if that's all you do, they're not going to get better. So, I think B is the best choice, even though I'm going to be doing B and C.
Yep. All right, good. And then this next question about TLS, tumor lysis syndrome. Which one of these drugs puts you at higher risk for it?
Yeah, so I think that A and E are both right, which I think is the hard part about this. What I was trying to get at with a high-risk patient is that you should really be thinking about giving them rasburicase, and you know, 4 times as many people recognize that. But if they're coming in, they've got a really high uric acid, you're going to give them alpurinol, so that's certainly not wrong. But you should also be thinking about giving them rasburicase. You know, give them that 6 milligram times 1 dose, and then you're really going to lower that uric acid so that when they start producing uric acid, maybe when they're starting their treatment or you know, as they have ongoing TLS, you're going to prevent that get damage to the kidneys. So I think A and E are both right.
Do you ever do both?
A and E?
Yeah.
Absolutely, yeah. So if I see somebody who's coming in with with an aggressive malignancy, leukemia, etc., I'm always going to start them on allopurinol. So you're not wrong, because I'm trying to prevent production there, right? So that's a xanthine oxidase inhibitor. So I'm not getting rid of the uric acid that I have, though. So if the uric acid's 10, I'm not going to get rid of that with allopurinol. I might produce less of it. So what is Ribeir's trying to do? It's trying to lower that up front so that if I'm going to continue, when I treat them, it's going to go back up again because I'm going to cause cell death. So I think A is always right, E is sometimes right. And so I think, honestly, I would say both of these are right, but the reason I put E as the right answer is because I wanted you to recognize there are patients who you should do it up front, not just when it's happening. Okay?
Okay. All right. Let me take one or two really quick questions here. Does anybody have any questions in the audience really quick? We're a little bit behind. Fantastic presentation. Helping me think about common presentations in bigger context. With these adverse events on the rise in hospitalized patients, could EPIC or EHR be trained to prompt us to think about chemotherapy or oncology-related syndromes in addition to focusing exclusively on sepsis?
Yeah, no, I think that leveraging the EMR could be for bioinformatics folks trying to leverage the EMR well. I think the challenge here is that, gosh, how many boxes and signals do you get in your EMR? We use Epic. How many pop-ups do you get? Like 20. And so how do we balance the fatigue that can happen from that, right? The fatigue that can happen from that many alerts with things that are really important to you. And so, yeah, I think obviously the sepsis protocols and things, because they're tied to reimbursement, are very, they're right front and center. But yeah, I mean, I think that maybe even a note that says, patient on immunotherapy, consider ICI would be something, right? Because then you're at least, I told you, if you're not thinking about it, you can't entertain the treatment of it. So I think that, yeah, certainly bioinformatics to do it. They just need to do it you'd have to do it in a very thoughtful way so that you're not just pelting people with, their 30th thing that they're going to click to discontinue so they can get to what they're doing.
What about cytokine storm?
So yeah, cytokine storm really is just cytokine release syndrome, more or less. We use cytokine release syndrome as the term for the adverse effect, but it's the same pathophysiologic process. I think cytokine storm we use more in like a disease pathophysiology point of view. An immune cytokine storm. I think, but they're the same processes in terms of what's happening to the patient.
One last question here: is dementia a possible adverse effect?
So, I'll address that. For ICIs, not that we know of. All right. So these been out for 7 to 10 years.
Different than delirium, right? So dementia as opposed to delirium.
Absolutely. So yeah, so more like long-term cognitive impairment is not really associated yet with the ICIs. The adaptive cell therapies we're still learning about. So that ICANS I told you about can kind of present in many ways, and there is some concern with a couple of the products, particularly one of the myeloma products, Carvykti, that it could contribute to Parkinsonism and maybe early Parkinson type features and actually cause some of those type symptoms. So it's absolutely a field of study because these are, we're impairing that blood-brain barrier, and what are we doing long-term for the brain? Well, we don't really know that much because these are in their infancy in terms of the use. So I think about these from a hospital perspective as more upfront management, right? The kind of acute ICANS, delirium type picture you might see, but will there be long-term lingering effects of these? We don't know for sure.
All right, great. So here, what I'd like to do is the following. So we have some boxed lunches outside, but here's the key. I want to get you guys out close to time, right? So we were planning on having a fireside chat over lunch, right? So can we take literally a 5-minute break, grab your lunch, come back. We're going to start our fireside chat. You can continue through the fireside chat to the next talk and also have lunch here, eat while you're doing that, but we're going to do both together, all right? Thumbs up, 2 thumbs up. All right, so 5 minutes, we'll have everybody come back. And we'll ask the speakers if you want to grab some lunch, please do, and we'll be back.